So please keep on continuing, even though we didn't answer those questions. Still keep on asking the questions. At the end of symposium, we'll answer those questions. Over to you, Chamara.
Thank you very much. Yes, really encouraged by the amount of questions that we are getting. So please do send in the questions. So the symposiums are for questions, and we'll try our best to get them across to the lecturers as well. So let's start off the symposium, the last one of the morning as well, Symposium 3. So cardiovascular disease, it's the leading cause of hospitalizations worldwide, and Sri Lanka is no different. We get so many patients with heart problems, cardiac diseases who are in our hospitals, and I think looking after them is very, very important as well. So essentially what we call rehabilitation. So the next lecturers are going to be talking about rehabilitating a cardiac patient. So to start off the symposium, may I introduce Dr. Chaminda Kularatne, consultant cardiologist at the National Hospital of Sri Lanka, Kandy, who will be talking about in-hospital rehabilitation, what to do. Over to you, Chaminda.
Good morning, everybody. Now we are moving to Symposium 3, Rehabilitating a Cardiac Patient. Topic I am going to discuss is in-hospital cardiac rehabilitation, what to do. Before discussing about my topic, I will discuss briefly about the basic concept of cardiac rehabilitation. Cardiac rehabilitation is an interdisciplinary team approach to patients with functional limitations secondary to heart disease. WHO has defined cardiac rehabilitation as sum of activity and intervention required to ensure the best possible physical, mental, social conditions so that patients with chronic or post-acute cardiovascular disease may regain their proper place in society and lead an active life. Cardiac rehabilitation has come a long way from initial bed rest approach. In 1950s and 60s, prolonged bed rest even up to 3 months was prescribed for patients following myocardial infarction. Advances of medical technology have led to shorter duration of hospitalization. The goals of cardiac rehabilitation cannot be achieved without multidisciplinary team approach. Multidisciplinary team include cardiologist, physical therapist, nursing officer, dietitian, occupational therapist, psychologist, and other health professionals like pharmacists. Myocardial infarction causes a significant decline in the social, physical, and psychological functionality of affected patient in addition to their medical problems. They might have a lot of questions to be answered. They might think, what happened to me? Am I going to be okay? Is this because of my boss? Why this happened only to me? What can I do? Will I be able to breadwin my family? Will I be able to go to normal work? These are the questions to be answered. So the goal of cardiac rehabilitation is to answer these burning questions of the cardiac patients. So the goals of inpatient rehabilitation is to promote secondary prevention and to enable quality of life among cardiac patients. This can be discussed on the medical goals, psychological goals, behavioral goals, social goals, and health service goals. I'm not going to discuss each and every one. So benefits of cardiac rehabilitation: to offset deleterious psychological and pathological effects of bed rest during hospitalization, enable patient to return to activities of daily living within the limits imposed by their disease, reduces cardiovascular and total mortality and morbidity, improved myocardial perfusion. What are the indications? Acute myocardial infarction, coronary artery bypass grafting, angioplasty with or without stenting, valve replacement or repair, heart transplantation surgery, congestive heart failure, and chronic stable angina pectoris. Conventionally, cardiac rehabilitation has been divided into 4 phases. Phase 1 is hospitalized period of the patient following acute myocardial infarction or acute cardiac event that averages up to 10 days. This depends on the patient medical status. Phase 2 is immediate post-discharge period. This extends up to 4 to 6 weeks. Phase 3 is stage of structured exercise program. This extends up to 6 to 12 weeks. And phase 4, maintenance phase, long-term maintenance of physical activity and lifestyle is important in this phase. Phase 1 occurs during the inpatient hospital stage or after a step change in the patient cardiac condition. I will be discussing about this phase 1 cardiac rehabilitation here onwards. Right? What are the core components of phase 1 cardiac rehabilitation? I will be discussing this under medical evaluation, reassurance and medical education, correction of cardiac misconception, risk factor assessment, early individualized mobilization, and discharge planning and patient discharge. Moving to medical evaluation, very important part. You have to take thorough history, including social history, physical examination, previous comorbid conditions, and patient current condition and its complications, and whether heart rate, blood pressure, oxygen saturation, all these things needs to be taken, and you have to risk stratify patient, whether patient is able to move forward with rehabilitation program. Right? Reassurance and medical education. So you have to tell the patient regarding their specific heart problem, what happened to them. Explain them with simple languages. You can use diagrams, heart models to explain this condition. And you have to give clear advice and information on what and when they can do their work, air travel, exercise, sexual activities, etc. So, as an example, driving, with regard to driving, car or motor license, motor vehicle, car or motor vehicle. So, patient who underwent angioplasty, they can drive in 1 week. Patient who had heart attack and underwent successful angioplasty, they can drive in 2 weeks' time. Like this, you have to advise clearly when they can resume their activities. With regard to air travel, so usually uncomplicated patient can travel in by air in 10 to 14 days time. You have to risk stratify before advising actually. And sexual activity, they can resume their sexual activity with their usual partners, usually after 10 to 14 days after discharge, if they feel to do so. Next thing is you have to give clear information about medication. So this is very important part. You have to take their medicine list and show them and tell them the importance of taking each medication and emphasize on importance and tell them what happens if they don't take their medication. We have seen patients admitting with myocardial infarction following stent implantation secondary to stent thrombosis because they haven't taken antiplatelet medications. To prevent these things, clear advice is very important. Then you have to clearly advise about managing their chest pain at home. So you all know how to advise regarding this problem, and they have to tell their risk factors and how they are going to manage their risk factors. I will discuss in ongoing slides. And they have to tell about lifestyle modification and stress management. These things will be discussed by one of my colleagues in subsequent lectures. So with regard to risk factor management, risk factors are traditionally divided into 2 groups, non-modifiable risk factors and modifiable risk factors. Age, gender and ethnicity are non-modifiable risk factors. Modifiable risk factors are smoking, diabetes mellitus, dyslipidemia, hypertension, obesity and sedentary lifestyle and stress. So I will be discussing few risk factors And so with regard to lipid management, you have to tell about the goals. Though most patients don't understand this, there will be patients who wants to know and who will understand, the educated people, they will understand. You have to tell them the goals. The LDL goal is less than 70, HDL is more than 40 milligrams per deciliter. The total cholesterol goal is less than 200 millimeter. Triglyceride goal is less than 150. With regard to blood pressure management, optimal blood pressure is 120 by 80. If blood pressure is more than 130/80, advice about lifestyle modification before discharge. You have to add drug therapy on patient with diabetes mellitus, heart failure, or renal failure. If the blood pressure is more than 140/90, advise lifestyle modification and initiate drug therapy. Right, near normal fasting blood sugar and HbA1c needs to be achieved with medication for diabetic patients, and obese patients actually we have to advise regular exercises and diet plan. You have to give a diet plan. Dietitian will assist for this thing to reduce their weight. Next thing I am moving is mobilization. So this is the most important part in cardiac rehabilitation in hospital. The main purpose of exercise therapy during the inpatient phase is to counteract the deleterious effects of prolonged bed rest. Activities include general range of motion exercise activities of daily living, including sitting, standing, and walking. Activities performed during phase 1 typically do not exceed 3 minutes. As soon as patient is medically stable, rehabilitation assessment should be completed and mobilization need to be started. Early mobilization should be guided by heart rate plus 20 to 30 unless patient becomes symptomatic. The aim is to avoid inactivity, maintain and improve pulmonary function and endurance, and maintain global muscle strength. Exercise have been seen to be beneficial for patients with coronary artery disease. However, vigorous exercises can have disastrous effects like worsening ischemia, left ventricular dysfunction, potential for life-threatening arrhythmia. Hence, proper risk stratification is needed prior to initiation of the exercise component of cardiac rehabilitation. It is essential to have graduation of exercises for a patient with coronary artery disease. So contraindications to exercise, I'm not going to these things. You can read unstable angina, untreated heart failure, and so on. Exercise intensity, my colleague will discuss about the exercise intensity. Post-acute myocardial infarction, you have to maintain heart rate below 120 or resting heart rate plus 120 beats per minute. So duration, intermittent sessions lasting from 3 to 5 minutes. Resting period, as the patient wishes, lasting from 1 to 2 minutes. Important thing is resting period should be shorter than the time of the exercise sessions. Total duration of 20 minutes per a session. So frequency, early mobilization 3 to 4 times per day. So how are you going to start mobilizing patient? First day, they have gone through a lot of problems. They had severe pain. They have gone to cath lab. First 24 hours, we led them to bed rest, and at the end of the first day, we start bed mobility, sitting on the bed, and we ask them to do the breathing exercises. And at the end of day 2, you can take patient out of the bed, and then day 3, short distance ambulation and bathroom privileges with monitoring. Day 4-5, you have to introduce home exercise program, including climbing stairs, and you have to increase the duration of ambulation. Next important part is discharge planning. Discharge planning is very important. Discharge planning is a multidisciplinary report where communication between the team members is necessary. The rehabilitation doctor should advise on the activities of daily living, mobilizing and progression of exercises which the patient can complete in phase 2. The rehabilitation doctor can give the patient a telephone number to the rehabilitation department so the patient can telephone if any questions. Right, prior to discharge, ideally, the patient has started to progress mobility within the limit of approximately 3 minutes. They may be able to walk up to 240 meters in 3 minutes if this feels comfortable to the individual. The patient should be independent in completing the home exercise program, which includes a warm-up and cool-down exercises, as well as a program of exercises to be progressed. The patient should also independently take their pulse and understand the use of Borg breathing scale. Actually, you can Google and see what Borg breathing scale is. And so after giving all those things, like you have given what happened to the patient and education regarding their condition, we have started the exercise program, we have told the patient about their medicines, we have emphasized about the importance of taking medications, and you have taught patient the exercises that they have to follow after going to home. So after achieving these things, we feel that patient can be safely discharged to the home and the society. I think I have discussed what to do in inpatient cardiac rehabilitation. Thank you very much for listening.
Thank you very much, Dr. Chaminda, for that very detailed explanation on what cardiac rehabilitation is and how to start a cardiac rehabilitation program. Essentially, I think it's very, very important that every hospital in the country where we have cardiac patients try to start a proper cardiac rehabilitation program. So I'm sure that information may be very useful. Moving on to the next lecture in this symposium, may I introduce